The Behavioural Insights team at Public Health England commissioned York Health Economic Consortium to conduct this piece of research. Screening can identify people who appear healthy but may be at increased risk of a disease. Within the NHS, a small number of conditions are formally screened for in the general population within the National Screening Programme. This study focused upon 3 population-based cancer screening programmes: breast, cervical and bowel cancer screening. Improving uptake for these programmes is important as it can improve health outcomes and also contribute towards addressing health inequalities. The overall aim of this study was to develop recommendations for Public Health England, which were informed by behavioural science methods. The recommendations were to optimise the design of real-world interventions which target health professionals' screening behaviours. Behavioural science methods provide insight into barriers and facilitators underpinning screening behaviours, which can then be linked to intervention design recommendations. Comparing these recommendations to the design of real-world interventions can therefore help to highlight missed opportunities in intervention design. The approach was framed around a behavioural science approach, therefore, and comprised of 4 stages: 1, to specify the target screening behaviours; 2, to identify the barriers and facilitators to health professionals performing these screening behaviours; 3, to identify real-world interventions that are designed to facilitate health professionals to perform these screening behaviours; and 4, to assess whether the real-world interventions are optimally designed. In terms of specifying the target screening behaviours, I reviewed the service specification documents for the 3 screening programmes and distilled these 10 healthcare professional screening behaviours that can support and facilitate patient uptake of screening. And these range from before screening, for example, encouraging providing access for people, through to providing good screening at the point of care, and through to providing good post-screening care and support, for example. We appreciate 10 is a high number to tackle this sort of project, but it was deemed important through discussion with Public Health England due to policy level focus of the project to include all 10, but to regard them as a related bundle of behaviours. To identify the barriers, a targeted and pragmatic literature search was designed and run. This was to identify papers that reported on barriers and or facilitators to healthcare professionals performing these 10 screening behaviours. And the papers had to have focused on one of the eligible screening programmes. Various pieces of information were extracted from the papers, but the key was supported barriers and facilitators, and these were then coded using the theoretical domains framework. For anyone not familiar with this framework, it summarises 14 domains or groupings of barriers that are said to influence the performance of behaviours. As you see here, in the summary table of the barriers and facilitators that we found, they were coded to 13 out of 14 of the TDF domains. This emphasises the plethora of barriers impact upon healthcare professionals' performance of those 10 screening behaviours. This was across 60 papers. And we see the most common barriers were coded as related to environmental context and resources around providing these screening behaviours, healthcare professionals' knowledge of screening and screening behaviours, and healthcare professionals' belief about consequences of screening and the screening behaviours. But it came to identifying real-world interventions. Around what email was sent to regional screening leads, asking for examples of such interventions that have been delivered within the past 10 years. Each intervention design that was provided was then coded using the behaviour change wheel and a taxonomy of behaviour change techniques. Behaviour change wheel maps barriers to different intervention functions and policy categories. Intervention functions and policy categories are basically components of intervention design. And a behaviour change wheel proposes there to be 7 different types of intervention functions. That could be an intervention may have the function of educating or training or persuading participants. Policy categories are almost like the methods of delivery, and the behaviour change wheel proposes 9 of these. They include things like providing guidelines via communication and marketing. The taxonomy summarises 93 behaviour change techniques. These are the smallest, most active intervention components. Thirty-one interventions were identified by the regional screening leads. And these covered each of the screening programmes, but more frequently the bowel cancer screening programme. The behaviour change wheel coding found that whilst a range of intervention functions and policy categories were observed across these 31 interventions, there was a tendency for them to try and educate participants through provision of, for example, online documents and links, resources, or to try and address and overcome barriers experienced by healthcare professionals, for example, through targeted training. There was less frequent use of intervention functions that drew upon modelling, persuasion, or environmental restructuring, and there was no observed use of intervention functions that were around incentivisation, coercion, or restriction. There was also less frequent use of environmental and social planning strategies. In terms of behaviour change techniques, again, there was reliance on what I call factual information provision and the provided resources, i.e. links to websites, and there was less use of what I see as more active techniques such as action planning and goal setting, and less use of techniques that have a more persuasive underpinning. For example, there's common use of techniques like drawing attention to health consequences of performing screen behaviours, less use of drawing attention to the salience of these consequences, or urging people to reflect on anticipated arrest if they, for example, didn't perform screen behaviours. When it came to assessing various interventions, the coded barrier and facilitators identified in the literature research were summarised in a table, and the intervention functions, policy categories, and behaviour change techniques recommended by behavioural scientists to tackle those TDF names were summarised alongside them. The functions, policy categories, and behaviour change techniques used in the real world interventions then highlighted. Those not highlighted thus represent missed opportunities in intervention design. Here we summarise the 2 most frequently coded to TDF domains by way of illustration. So remembering those that are summarised, those that are not involved represent missed opportunities in intervention design. The ones involved are ones that are recommended by behavioural scientists to tackle the TDF domain and were observed in use in real world interventions. So generally speaking, real intervention design is largely aimed with designs recommended by behavioural scientists to tackle the sorts of barriers and facilitators that appear to influence those. In the 13 TDFs, certain missed opportunities in intervention design were noted, and these were then drawn upon when devising recommendations, particularly certain over-reliance of certain behaviour techniques. So the recommendations, of which there were a number, had to be summarised in a certain way. So we wrote down in terms of the actual barriers of facilitators. So we recommended that to Public Health England to ensure future education, training, intervention cover the important topics identified from the literature review. So not only did it according to TDF, but we also distilled themes of barriers within each TDF domain to give more flavour and more information to Public Health England going forwards. We also devised recommendations relating to type of intervention function, policy category and behaviour change techniques to use, included so to continue with the use of a range of intervention functions, but to also look to use the functions of persuasion, modelling and environmental restructuring alongside more commonly used education, training and enablement intervention functions. We also recommended to encourage more active participation in education training interventions and to draw upon a broader range of behaviour change techniques. So we suggested techniques like encouraging health professionals to reflect on the pros and cons of performing a particular screen behaviour, or to engage in problem solving, and to also use a credible source to deliver training, for example. We finally devised recommendations relating to specific types of interventions that could be used. An example here would be to review and promote different models of providing screening. Overall, there was a number of detailed recommendations that were broken down to these areas. For more information, a manuscript is currently under review, and our result will also be published as a report on the Public Health England website. Thank you for your time.